ever since I started becoming a doctor during my training in the armed forces, my thesis was on CS cervix. And now, after 2 decades, to sit with such an esteemed, faculty and, to see everybody coming together. They say that when you really want something, all the forces of nature work towards it. And this has been so frustrating, I think, for all of us over these years that something is preventable, something is doable, but nobody does it. And you will not believe it, all of us are guilty. I mean, I stand guilty. How many times have I done a pap smear? And, I always ask that question whenever I take a talk, and I ask people that, have you actually done a pap smear? You're giving gyan to everybody. Have you done it? So, we're all guilty. So I think all the people before me have spoken so well. And first, I would just like to, just reiterate all of that because everything is so important, right? So the WHO stand is very important because when WHO, narrative goes out and everybody takes cognizance, people are a little more attentive. So, I think it's going to really help. And when you put a deadline to something, there is a competition to achieve it before the deadline, by all the stakeholders. So I'm happy, that has happened. And also very happy to hear, Madam Puri and, Dr. Kaur. I think amazing inputs and hats off to our survivor and, really hats off to you. You're just amazing. So I think very well touched upon. If we are not going to do it now, as Dr. Satinder said, when everybody has studied from the WhatsApp University and Google University and become an expert on diagnostics, if I may say, till 2 years back, nobody had a clue what is quality control, what is PCR, what is ICMR, and what is POC testing, and what do you mean by sensitivity, specificity. I had to bang my head sometimes, when I used to talk about conventional pap smear, liquid pap smear, and the various HPV. And now it's like people are teaching us, and I'm like, oh, okay, good. Now you know everything. Now go ahead and do it. So still, I would like to, for the benefit of the audience, just like to recapitulate the entire journey of cervical cancer screening. So I always believe, as our principal said, that, the young know it all. I mean, they're so sharp. I learn every day. I have two daughters, one 14 and one 10, and they know it all. And my 14-year-old girl is vaccinated for HPV. And when I told her, she said, Mom, there's something like that available. Let's just go take the vaccine. She was not scared, as, she rightly said. She was not scared at all. And she was like, I don't know what's going to happen tomorrow. I might as well take the vaccine if something is available. Now she's even taken her COVID shot. So these kids are smart, right? So there is no doubt about it. And our elders were also smart. Now it's how smart are we? I think it's our time to deliver. So, I always feel you have to learn from your, seniors and elders, and you have to also learn from your young. And then you have to deliver if you're in that position. You're in a position of power to deliver. So we cannot, proceed this conversation without, thanking two people, Zurhausen, who actually discovered that HPV causes cancer, right? As, so many people said, and how many cancers do we know what's the reason? But here we know what's the reason. And that's because of one person, Zurhausen, who connected HPV to cancer. The second person is Papanicolaou himself. So pap smear has stood the test of time, and for the last 20 years that we've been, at least I've been using it, and I cannot tell you of how many women have got detected, have got treated, so it is. And it's very interesting to know that he actually tried it on his wife, right? So he used to take her sample. I don't know how many people are aware of this. So, Mrs. Papanicolaou has a bigger contribution to this. Somebody mentioned the importance of spouse. So yes, nothing is possible in this world without support of your spouse and, your family. And, there were two things that really helped Papanicolaou. One was that, how would he study this association? So he actually took his own wife's sample at different time intervals to see what happens to those cells. And then how do they change, shape and, size, and how do you detect that, okay, now this is, precancerous. And the second thing that helped was collaboration, what we all touched upon, that until you collaborate, you cannot live in a silo and hope to do anything, right? So collaboration is the key. And when he started collaborating with gynecologists and understanding, oh, it is at this stage where you can intervene, where you can treat, where you can, help someone. That is how, this whole journey progressed. So when we talk about cervical cancer screening, definitely the first test, which has stood its test of time for 50, 60 years now, is the pap smear, definitely. But let us understand what has happened. Pap smear is a wonderful test. I'm a cytopathologist, so I love the test. But I also know what goes wrong, right? I also know what goes wrong. So two, three things go wrong. First of all, you need experts to read those slides. Now, experts are not available everywhere. And if we want to do something in a mass level, we are not going to get so much resources or manpower, right? So the next best thing was to do a liquid-based cytology approach. So the whole conventional pap smear went into liquid-based cytology, and that definitely helped us. And we have an international publication, in fact, on this, on huge number of women. And the number of cases that we could detect by LVC would double, just simply double of conventional pap smear. That is the way the sensitivity increased. Now let's talk about HPV. So at least till now, whether it was the American societies, whether it was the US Preventive Services Task Force, or whoever it was, everybody said that it is better to do a co-test, HPV as well as a pap smear. And if you do a co-test, you can get away with doing the test every 5 years only. We know compliance is an issue. We all know. So, and also how many times is the manpower going to go and, sort of take all these samples? So the whole journey of co-test started, and it definitely improved compliance. I have seen many, many more people now do screening, because now they don't have to see. Earlier pap smear used to run every year. Then it became you have to do cytology only 3 years. Then it became if you couple a HPV with a cytology, you have to do it only 5 years. So we kept on increasing the duration of the screening, and we kept on increasing the sensitivity and the specificity of the screening, and we started achieving good results. But there's a plateau, right? We are still losing women. So, you are lucky, you're a survivor. But trust me, till today, I sign out at least 1 to 2 cervical cancer cases every day. And half the women are not so lucky. They are in stage 4 by the time we diagnose them. And we all know that the survival in stage 4 is, not even. So the survival is between 36 to 60%, what is published, and 46 is an average. So that means that each and every cervical cancer patient, diagnosed, we are going to lose nearly half of them as we stand today. And that is a very, very dismal number, and something that India is not at all proud of, should not be proud of. So what should we do about it? So as correctly said, the best way to do is to, follow the global strategy, try and vaccinate as much of our girls as we can, and try and screen as many of the women as we can between 30 and 65 years of age. And whoever we catch, we should treat them. Now, what is the watershed moment in screening actually? And what is the whole debate and the whole confusion about today? That is that the whole mindset or the whole wave is changing from making high-risk HPV as the primary screening. Now, that is a big, big, big change, right? And trust me, people are not even ready for this change, in the sense, not in terms of technology and infra. Ready, I mean in that way, right? So if that is what has happened, then we all have to get ready. Now, what does it mean, right? So it means that, see, till today, I mean, 2001, say we have a, hybrid capture test, which has been approved by FDA, and there are many kits which are FDA approved for, HPV testing, but not all of them are approved for primary screening, right? So I would really try to take this cue from what Dr. Satinder Kaur said, actually, very, very good point, that today, the amount of infra that is developed for COVID, okay, there are so many molecular labs that have mushroomed. So I was in a conference in Haryana 2 months back, and I was shocked to know, I was interacting with the Deputy Director, General Health Services, and she was, telling me how each of their government labs now has a molecular unit, shaping up. I mean, that's amazing to know that, that there are so many, and we all know the ICMR data and the number of labs and the number of accredited labs. So first of all, there were labs, but they were not accredited. Then even if they were accredited, they were not, sometimes not, on the same page as far as the kits are concerned. So today there is a, it's all very synchronous, right? So everything is controlled. There is a certain degree of control that these are the kits which should be used. These are the acceptable sensitivity. There is an acceptable specificity. So many people have got trained. Today, the number of molecular biologists and the number of microbiologists, they are booming. They have got trained. Virologists. Today, we have virologists. Now, Metropolis itself is opening another center of excellence for virology in Africa because we felt that, it's not. So as we all know, Africa has a very, very high number of these cases. And we used to get a lot of samples from them. But during the COVID, scenario, we realized that logistics is a big issue. And, all our people who we collaborate with over there, very, very senior doctors, government officials, they told us this is not working out. We can't even get the samples to you. And our patients are losing out. And we realized, okay, we need to invest. We need to make a center of excellence in Africa itself. So what I'm trying to say is that today there are multiple centers of excellence of virology shaping up across the world. And if that is going to help anything after this damn COVID is out of our life, it's going to help the cervical cancer, right? Because, obviously now with Omicron, it's such a puny variant of the, corona. And I think it's the best way to get out of the pandemic unless we have another surprise by a virulent strain. So, the whole thing is that now it's going away. It's tortured us for 2 years. But I think it's going to leave, some very key things that were missing to actually combat cervical cancer. What was missing was the infra, the focus on health, the quality, the people, the manpower, the follow-up. Digitization is what was missing. Today, digitization is rampant, and that is going to help us like anything. Artificial intelligence. So even the VIA technology, that ma'am mentioned, that, doctor is not even required, but still you're dependent on the the basic intelligence or, the experience of the person who's seeing it. But today there are AI algorithms and you can put all the pictures together and you can actually say which one is what. So, all this AI and, digitization and automation that has got developed for COVID, I think is going to help many, 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 other diseases. Not only cervical cancer, it's going to help many diseases. So I think now the writing on the wall is very clear that we all have to arrive at a primary screening HPV test, which can be offered at a mass level. And another thing that is very important is the self-sampling, right? So today the data of COVID is all over the place because nobody knows the real data because of the rat, right? So earlier everybody with huge diligence was getting everything done in a proper RT-PCR from a lab. But today everybody's become very smart. Everybody's picked up, all the rapid antigen kits. They have a whole lot of them in their house. Oh, you thinking you're positive? Okay. Oh, you went out? Oh, my maid, oh, my this, tuck. And before I know it, everybody is like, okay, this is positive, this is control. I'm like, also what is the meaning of control? What is lateral flow? But it is such an exciting moment, right? So it's good. So it's good that so many people are now aware of this. And I think self-sampling is the way to go. Women are shy, women don't have time, women don't focus on their own health. Even if they do, they have to go with somebody. Some people are still dependent. Everybody is not so privileged like most of us in the metropolitan and cosmopolitan cities. And as one of the panelists mentioned, this is a cancer which is unfortunately more common in the lower strata of society, whether it's because of their immunity, hygiene, multiple other factors, or just ignorance, or no money, no time, lots of things. So I think when we're going to couple self-sampling with a good primary screening of HPV, we are definitely going to catch, more women. The only doubt that, people have, and, College of American Pathologists has also highlighted this area, which we all know, that even though HPV screening has got an excellent negative predictive value and excellent sensitivity, it is poor in specificity and in the positive predictive value. And there is where the importance of triaging is going to come. Now, how are you going to triage it, right? So either you see HPV prevalence, when we looked at it in thousands of our cases, we found across 9% prevalence. So 9% people are but not CS cervix positive, right? So there are a whole lot of people who are going to be HPV positive because, as somebody said, it's very, very common in the sexually active age group. So even though they are going to be HPV positive, they're really not going to have anything to treat because there is going to be no lesion. And that actually can only be seen by cytology or by colposcopy. So again, you will have to develop that triaging and that reflex, and that where you are able to then, from the HPV positive women, identify the women through colposcopy or through cytology who actually need what treatment they do need, for that particular stage in which they have got caught, because there is a huge time period in which they get caught. So, because every time the treatment is not so aggressive, right? So it varies from your, different modalities, which I think will be covered by another speaker. So I'll not go there. So, but basically that's what it is. So let's welcome this era where we are going to start active primary screening by HPV, and hope to link it with tests which help us to actually identify the women who need treatment and what treatment do they need. So yeah, so thank you.